Okay, can everyone see that? Okay, just a few more of you guys. Okay, we'll go ahead and get started. So this is one of your HESI review Kahoot options. There's a couple others, and then I put all week 1 through week 9 material on there too for you guys to review for Kahoots. Toddler swallows grandma's digoxin. What should you anticipate? Red is have the child vomit immediately. Blue is have digoxin aminofab ready. Yellow is eat a banana. And green is check the child's pulse. Yes. Digibind. Have that ready so that way it can bind with the digoxin and hopefully the kiddo doesn't get toxic. Good. Okay, and multiple select. Signs of respiratory distress in infants. Red is restlessness. Blue is flaring nostrils. Yellow is grunting. Green is bradycardia. Yes, good. And it wouldn't be bradycardia. What would it be when they're in respiratory distress?
Tachycardia.
Tachycardia. Good. Okay, when a pediatric patient has an amputation, what priority teaching is very important? Red is inspect the stump for skin breakdown to prevent infection. Blue is keep the stump open to air. Yellow is wash stump with betadine. Green is range of motion exercises. Yes, keep an eye on it for skin breakdown. That's your most important teaching. What is acute myelocytic leukemia, AML, in children, and what are the symptoms? Red is anemia. Blue is frequent infections. Yellow is bone and joint pain. Green is bruising. Yes, all of those are possible signs of AML. Okay. Good. Multiple select. What may be a problem seen after surgery for tetralogy of Fallot? Red is low heart rate. Blue is poor appetite. Yellow is fatigue. Green is respiratory distress related to congestive heart failure. Yes, so poor appetite, fatigue, and respiratory distress because of congestive heart failure potentially can be complications after surgery. Usually it's high heart rate and not low heart rate. Good. Multiple select. What defects are associated with tetralogy of Fallot? Red is pulmonary tract obstruction. Blue is right ventricular hypertrophy. Yellow is VSD. Green is aortic stenosis. So it's pulmonary tract obstruction, right ventricular hypertrophy, and VSD. No aortic stenosis. Okay. Good. An 18-year-old's parents want lab results. Red is do not give out as it's against hospital policy. Blue is get permission from the 18-year-old. Yellow is get written permission. Green is you may give the parents the information. Yep, so you can get permission from the child, the 18-year-old. Okay. But unless you get permission from them, since they are at 18, no longer a minor, then the parent does not have any right to that information, even if it's under their insurance. Okay, what is Synagist and why is it given? Closes the PDA, which is red. Blue, RSV vaccine. Yellow, antibiotic. Green is growth hormone. Yeah, blue, it's the RSV vaccine. Synagis is an RSV vaccine. And you give it to hopefully give those kids some antibodies to RSV so that way they do not get significantly ill with RSV. Their immune system can recognize the antibodies and make antibodies to RSV before they become significantly ill is the goal with Synagist. And it's once a month all through respiratory season. So usually October through March. Okay. What is the highest priority with a preoperative infant with bladder exstrophy? Red, monitor urine output. Blue, monitor daily weights. Yellow, risk for infection. Green, take abdominal growths. Yes, risk for infection. What's bladder exstrophy? Remember?
It's where it's when the baby's born, it's born on the outside.
Yep, instead of being within the abdomen, it's outside the abdomen. So your biggest concern would be that bladder or that tissue becoming infected. Okay, good. "10-year-old wants an insulin pump for type 1 diabetes. Red, not a good option. Blue, not available until they are 18. Yellow, a good option for a 10-year-old. Green, only the adults get insulin pumps." Yes, it is a good option for a 10-year-old. Okay, most 10-year-olds. Obviously, if we have a developmentally delayed 10-year-olds, then we might need to think about that a little bit more. But for most 10-year-olds, that's appropriate. Good. Multiple select. When and why would Lyme test be done for a child? To detect tick bites is red. Blue is blood test to detect Borrelia burgdorferi. Yellow is testing is done 1 to 2 weeks after exposure. Green is to detect gastroenteritis. Yes, good. It's a blood test to detect Borrelia burgdorferi. And testing has to be done 1 to 2 weeks after the tick bite. Otherwise, it could be false positive. Okay. And then because it's related to tick bites, if it's positive, then it helps you detect on whether or not they actually had a tick bite. Usually kids, though, who have Lyme, what do they usually wind up manifesting? Like what symptoms? What's the first thing that you notice if a kiddo has Lyme usually?
Not flu-like symptoms, is it?
The bullseye.
Bullseye rash.
Bullseye rash. Yep. Good. Good. That's the big thing to know with Lyme. Usually it starts with bullseye rash. Good. What might you see after administering a bolus of albumin to a child? Red, noisy respirations. Blue, constipation. Yellow, increased urinary output. Or green, peripheral edema. Yes, good. Increase urinary output because that's going to pull the fluid. Albumin, if kids are getting albumin, they're usually retaining fluid and edematous. So by giving them albumin, then you increase their urinary output is the goal. Good. Okay, multiple select. What is another term for erythema infectiosum? Fifth's disease, which is red. Blue is slapped face. Yellow is measles. Or green is chickenpox. Yes, good. Fifth's disease is the name for it. And then, okay, can everyone else see my screen okay?
No, it keeps randomly going black and you're skipping and
it's
Really?
lagging so bad.
Yeah, and like I
the
don't.
lag is awful.
It's lagging.
Okay.
It said that I had 8 seconds left and then it cut me off and didn't take my answer.
Okay. Has it been doing that the whole time?
Yes.
Yeah.
Oh, okay.
Been trying to get through it anyway.
do we want to just go to the PowerPoint then?
Yes.
Okay. Okay, let's go to the PowerPoint instead. Okay, since Cahoots wasn't working, I do highly suggest you guys go through those and then also go through the weeks 1 through 9 Cahoots to the individual week Cahoots. Those will be helpful for review. Okay. Hang on, it's flipping to the view slides. Okay. Okay. You guys see that okay? So remember, for growth and development, you have to have proper nutrition. So feeding to figure out how many calories kids need or kilocalories they need, it's 108 kilocalories per kilogram per day that these kids need. And that's to ensure that they're growing properly. Okay. If kiddos, you're doing their growth charts and they're starting to drop off of their growth charts, it's important to talk with parents about how much they're eating and trying to figure out if they're getting enough calories to be able to grow appropriately. If they're not getting enough calories, then speaking with the parents about increasing their nutritional intake would be important. But also, if they are getting enough calories and they're still dropping off the growth chart, there could be some sort of growth delay going on. So that would be important to investigate. Okay. If a kiddo falls and bumps their head, the first thing to do is your neuro assessment. So try to prioritize things as you're doing your HESI. A lot of the answers will seem like they're all right, but the question usually is looking for your priority answer. So make sure you're picking the priority answers unless it's asking for another answer. Okay. Preferred injection site, remember, on all kids is the vastus lateralis. If they're an adolescent, then a deltoid is an option as well, but for little kids, so I would say 4, 5 and under, vastus lateralis is going to be your option. Okay. You're not giving Epicac to induce vomiting, okay, because of the rebound corrosion to the throat. Okay. Usually maybe activated charcoal, but you have to do that with a gastric lavage, so the tube to the stomach if they're ingesting something. Growth and development. So remember your milestones, look at your theorists again, use your HESI book It's page 192 in the HESI book, okay? So what sort of things is a 4-month-old expected to be doing?
Pomegranates.
What did you say? Sorry. So what should 4-month-olds be doing?
Like pomegranates.
Palmer grass, probably a little early for that. It's probably closer to 6 months. What about rolling? Right?
I thought
Then
rolling typically happens around 5 months.
rolling back.
Abdomen to the back.
Yep, belly to back first. That's usually around 4 months, and then back to belly is later, closer to 5-6 months. But look again at all of those milestones. Okay. Head control, doing tummy time. Okay. And remember, kids don't have to go in the step approach. They can kind of skip here and there as long as they're meeting all of the milestones around the same time. Okay. And look at again at your theorist. Okay. Self-feed, spoon and cup, 18 months to 2 years. Okay. Look again at theorist. Okay. So if you have a kiddo with cognitive impairments or developmental delays, the quicker you can refer them, the better. Okay. As soon as you're identifying that impairment, they should be referred. Okay, here's Erickson's. Okay, so look again at Erickson's. Of course, for peds, it only goes up through adolescence. Okay, so we only go through identity versus role confusion. Okay, but look again at Erickson's. What concept in an infant would reinforce that they've met trust versus mistrust? So what would show you that an infant is in the trust versus mistrust period?
When the baby is crying, the mom picks him up, then that's trust. But if the baby is crying and the mom doesn't pick him up, that's mistrust. It could develop mistrust.
Yep. Or like they're crying and they have their diaper changed, or they're crying and they get fed, and they start to learn that if they cry, then their parents are going to do what they need to do. Good. Okay, so school age, it's industry versus inferiority. So that means that they're mastering a task if they're industrious. So they're getting really good at doing that task. Okay. Kohlberg's pre-conventional level of moral development, a preschooler. They understand good and bad, and that good and bad have consequences. Okay. So pre-conventional in a preschooler is understanding that good or bad actions have consequences. Remember Maslow's hierarchy, okay, and how all of these things are somewhat necessary to kind of move to the next stage in the pyramid, okay? So preschoolers who are reluctant to take oral medications. So it's best to use a straightforward approach. With preschoolers, things like rewards can be helpful. So like sticker charts, or they get a treat if they take their medicine like they should. Okay. And then the other piece, just like any kiddo, even with preschoolers or whatever age, you have to look at the individual child's developmental levels. So if they're functioning on, an infant's developmental level, then, you're going to have to use a different approach with them taking medication. Okay. If kids are hospitalized, it is easier if you give the parent the medicine and watch the parent give the medicine to the child while you're in the room. That's probably the most beneficial way to do that. So adolescents, they can give you the information about themselves. Parents don't necessarily have to be in the room. It is important to talk to adolescents alone. And it is okay to ask the parents to step out. If the child says, no, it's totally fine, I want my parents in here, they know everything that's going on in my life, then you can allow them to stay in if it's that adolescent's request. But ideally, you're able to talk with that adolescent alone, because then they can be more open and honest with you about, sexual things that maybe they don't want their parents to be aware of, or drug use, alcohol use, vaping, things like that. And the only thing that you have to tell their parent is what?
If there's like a risk for abuse or
There may
abuse
be
or
like
or
suicide, right? Yep. Suicidal, homicidal, so risk to themselves, risk to somebody else. Abuse wise, the parent could be the abuser. So in that scenario, I probably would not share that information. I would just try to keep the kiddo there in the office while you get a hold of DHS or law enforcement for further steps. But definitely, if the abuse is happening by somebody else and the child wants to talk to the parent about it with you, then that's fine. But safety concerns for the child or others. Okay, integral feeding goals. So the goal is to help with normal organ development, normal growth and development. So some infants that especially are early, like premature infants, may struggle with bottling. So they may need integral tube feedings for a period of time. If they are infants, you really want to use a pacifier while they're getting their tube feeds, because that continues to encourage them to suck, swallow, and breathe, to continue to have that reflux. So when that tube comes out, they're able to eat more successfully. Okay. What are 2 contraindications for giving a child a live vaccine? Why would you not give a child a live vaccine?
bone marrow or albumin considerations.
Good. Immunocompromised, kiddos taking steroids. Okay. Somebody else in the home is immunocompromised. You may not want to do that just for risk of that individual getting that illness. Okay. Bone marrow aspiration. After they've had a bone marrow aspiration, what are you going to do nursing management wise? You're going to watch for bleeding after a bone marrow aspiration, watch for infection. You're going to educate them on what they may need to monitor for, okay? And reducing the pain as much as you can, and then activity as tolerated, okay? Bone marrow aspiration and biopsy is a part of leukemia workup, and it's actually a part of most malignant workups, along with CBC and smears. Okay, administering albumin, what are your considerations? What are you going to be monitoring? You're giving kids albumin because they're holding on to fluid, right? So what would you be monitoring if you're giving them albumin?
Eyes and nose.
Mhm.
Edema.
Yeah, eyes and nose. Yep, their output. Good. Albumin is considered a blood product, so you have to have your 2-person check. Okay. You have to do all your dosage checks with 2 people. When you're setting up your pump, you have to do that with 2 people. You know, making sure that your product is matching what you've received with the order. And then obviously checking to see that consent is signed and that, you know, kids haven't had a previous transfusion reaction. And if they have, then you want to be on, you know, extra high alert. Okay. How should burns be assessed in the child?
Yeah, the rolling nines.
Mm-hmm. Good. Yes, the rule of 9. So based on where the burn is how you score the severity. Okay. Head, neck are considered one part of the body. Okay. Trunk goes along with that too for infants. Okay. And if kids have burns, then they need to be on high calorie, high protein diet because of the need, the nutritional need that burns place on the body. Okay. Hospitalization. So siblings, if they have a sibling who's hospitalized, the child who is hospitalized and also the child at home, a lot of times will have some loneliness, fear, worry. They might be jealous because the kiddo who's in the hospital is getting more attention than they are at home. The routine of the family is probably also going to be disrupted. So just keeping an eye and letting parents know to keep an eye on the kiddos who are at home. Allowing the kiddo to come to the hospital if able. Some hospitals during respiratory season, they have some policies that kids cannot come during that time frame for risk of infection. So just encouraging parents to involve the sibling as much as they possibly can and answering any questions that they may have appropriately. What are early signs the nurse should assess when lead poisoning is suspected?
Headache, vomiting,
Mhm.
abdominal pain.
Yeah, good. Yeah, anorexia, lethargy. They might start kind of having ADHD type symptoms. Okay. And it's the #1 cause of anemia. So, you know, you're going to get kind of those anemic type symptoms too. Lead is found in multiple places. Sometimes it's in like soil, it's in soil potentially, outdoor pollutants, certain foods, candies, beverages, specifically from countries like Mexico or India, like home remedies that they do, that some cultures do, that can contain lead. And then, of course, paint and gasoline prior to 1988. So the gasoline piece should no longer be a factor, but leaded gasoline used to be a thing. And it definitely decreased IQs and increased the risk for lead. Okay, hearing assessments. So what should prompt a hearing assessment is lack of startle response in an infant. Absence of babbling by age 7 months would be concerning. General indifference or not bothered by sound. Lack of spoken word or a response to spoken word. And then it's best to try to detect this within the first 3 to 6 months of age, so that way their language and speech development isn't as affected. Okay, so if any of these things start, or it seemed like to parents they were hearing well, and then all of a sudden now they're not hearing well, or they're not responding like they were previously, then you need to do a new hearing exam. Chronic kidney disease teaching. So the biggest thing with chronic kidney disease is going to be monitoring your I's and O's and weights, okay? Keeping an eye on their respiratory effort as well. Kids with chronic kidney disease, what sort of things dietary wise may go on, may be restricted?
Salt.
Yep. What else?
Any foods like high in potassium?
Potentially.
Potentially.
What about fluids? Right? Fluid restrictions might be a part of it. Okay. And then keeping an eye on the patient and the family response to treatment. And like you said, Ebony, the hyperkalemia, goodness. So high potassium, keeping an eye on that. Doing erythropoietin because they're going to have decreased red blood cells because of their kidney dysfunction. Okay. And then keeping an eye on their vitamin D levels as well. Okay, what would you teach parents on hypospadias, epispadias when it's corrected? So foreskin is usually used in the correction process. So circumcision is not completed like it is initially in kids who do not have epispadias or hypospadias. You do not want to manipulate once the stent is placed. You do not want to touch that stent. And then you want to continue to have the kiddo in a diaper to prevent any leakage. Nephrotic syndrome, so this is protein in the urine because these kids will be getting albumin and Lasix, okay, because of the risk of fluid overload related to the proteinuria, okay. These kids will have decreased blood pressures. Usually they need to be on a low sodium diet and fluid restricted. INO and daily weights are going to be your nursing cares. Okay. Hemophilia, joint care. What are you doing for hemophilia?
Pain management, drawing blood from joints, possibly surgery.
What else? There's a medicine that parents can give.
Vitamin K.
DDAVP is something that parents can give at home for the factor. Okay. Rice is also a part of hemophilia. Okay. But yeah, surgery, draining the joint, potentially giving the factor at home, which is DDAVP in hemophilia's case, and then pain management. Good. Respiratory distress, if it progresses, it can lead to respiratory failure, which then leads to cardiopulmonary arrest. Okay. So mild respiratory distress might be tachycardia, tachypnea, but then moderate starts. So that's where you get your increased abdominal breathing, your increased retractions, grunting. Kids might start to become more anxious, headaches, high blood pressure. Okay. So as it's progressing to moderate, that's where they need to be in the ER. Okay. What would cause an infant to have nasal flaring?
Respiratory issues, trouble breathing.
Yeah, so infants are obligatory nose breathers, so they can only breathe through their nose. So if there is any gunk in their nose, that needs suctioned out because they do not know how to breathe through their mouths. Okay. So flaring nares in an infant is showing you that that kiddo cannot breathe the way that they need to, and they need suctioned. So asthma, exacerbation, what does that usually look like management wise? So status asthmaticus means that there is an asthma exacerbation that's causing hypoxemia. So they're getting hypoxic from their asthma. Then eventually it can progress to respiratory failure. And then pneumonia can also be a factor for some of these kiddos with asthma. So when a kiddo is in an asthma exacerbation, what is something that is usually given?
Albuterol.
Uh-huh. What else could be given?
Furosemide. It starts with an F.
How about steroids? Oral steroids, IV steroids if they're coming into the ER in an asthma attack. Sometimes famotidine is given. That might be what you're thinking of, because that can help kind of with any of the H2 that's going on, that can be activated potentially with asthma exacerbations. And then pneumonia, of course, we've all heard of pneumonia. That's when you get gunk in your lung and it becomes infected. That can also happen in asthma. But the most common cause of viral pneumonia, specifically in kids less than 2, what virus is that? Do we remember? Okay, I'll give it to you. Respiratory syncytial virus, RSV. Okay. That's the most common cause. Okay. So a child who has asthma is having worsening wheezing for the last couple days. They use an inhaler. What's your most important question? It is asking if they use their spacer with their MDI. If they did not use their spacer, that would be the first thing that needs to happen in the ER is utilize their spacer or a spacer with their metered dose inhaler and see if that calms their wheezing down better. Kids should always use spacers with inhalers. Actually, it's been recommended now that even adults use spacers with their inhalers to absorb their medication better. Epiglottitis, remember this is a toxic emergent scenario, okay? These kids will start tripoding. You can see that this is what these kids are doing in this picture, trying to lean forward. You see excessive drooling. They're trying to lean forward, get in that tripod position to try and get as much air into their airway as possible. And this is an emergent scenario. Usually they need intubated, and a lot of times intubation is not able to be performed quickly enough, so they may need a temporary trach placement, and they're given steroids. Okay. So frog-like croaking plus cyanosis. It may have some inflamed, bulging, tympanic membranes that kind of look like an ear infection. Okay. High fever usually as well. So epiglottitis has been significantly prevented because of the Haemophilus influenza vaccine that we do, or the HIB vaccine that we give kiddos now. But if they haven't been vaccinated, which like we talked about during vaccines, a lot of times this is becoming more prevalent now, since there's not such a good herd immunity from a lot of vaccines any longer. These kids will start to see this happening more often. So IV antibiotics, having the kiddos sit in an upright position, these kids will go to the ICU. Okay. After they're intubated, or if they have to have a trach placed temporarily, then you'll be getting blood cultures and IV antibiotics, usually rifampin or ceftazidime is given to the people in the household. Because the other thing you worry about with Haemophilus influenza is not only epiglottitis, but also meningitis. Okay. Hyperglycemia complications. So what sort of things do you see if a kiddo's hyperglycemic?
Breath smells.
Uh-huh.
Flushed cheeks, possibly.
Yeah. What's their mental status going to be like?
Confused.
Mm-hmm. Yep. Good. And then eventually they'll go into metabolic acidosis. Okay, so then you're going to see the Kussmaul's respirations. Okay. And that happens with DKA. Good. So a kiddo, an 8-year-old who's semi-conscious, is brought into the ER with a blood sugar greater than 600. Their potassium is 6.8. The pH is 7.12. HCO3 is 15. What's your priority?
Insulin.
Mm-hmm. So the priority would be getting an IV in that kiddo and getting them bolus with normal saline and insulin. Yep, good. Okay, what's the difference between right to left shunt and a left to right shunt in cardiac disease? Let's start with right to left. What sort of defect are you going to have if it's right side to left side shunting? Is it going to be cyanotic or acyanotic? Right to left shunt is cyanotic or acyanotic lesions.
They're cyanotic.
Right side to left side is going to be cyanotic. Yep, good. Left to right is acyanotic. So we'll talk about right to left is cyanotic. So that's going to be your 5 T's. So truncus arteriosus, transposition of the great arteries, tricuspid atresia, tetralogy of flow, and total anomalous pulmonary vascular reserve, or TAPVR. Okay. So transposition is where the two vessels switch. Okay. Tricuspid is your third, your narrowing of your tricuspid valve. Okay. Tetralogy of flow, there's 4 defects. Okay. This is you trying to remember some tips here. And then 5 letters, TAPVR. So total anomalous pulmonary vascular return. Your acyanotic lesions, which is left to right shunt, are your ASD, your VSD, your PDA, and your coarctation of the aorta. Okay. DIG or Lejoxin. So the goal is to keep them their heart rate within a normal range. That's your goal of when a kiddo takes DIG. Usually it's given twice a day for several months or years after cardiac surgery or cardiac interventions. It helps to pump the blood more effectively. It increases the circulation of the blood and then promotes elimination of any excess fluid. Therapeutic levels are 0.8 to 2 nanograms per milliliters. Obviously, if they're hypokalemic, they're hypercalcemic, hypomagnesium, that can mess with the DIG level. So if any of those are off, it would be important to be being very cautious with giving digoxin. Okay. Before starting digoxin, there needs to be a baseline EKG, and then every time you give digoxin, you have to get an apical pulse, so listening to the heart for a full minute, okay, prior to administering, and also blood pressures, okay. If less than 100 beats per minute for kids, then you're going to hold the dig, and if it's less than 60 for adults, you're going to hold it, okay. If they're staying bradycardic, then you're going to want to do draw a drug level, okay. If kids ingest digoxin that is not theirs, then they need Digibind, okay. Usually you want to give dig also 20 to 30 minutes before they're eating, okay. So it's a part of the routine, but you don't give it in food or formula because then you're not sure how much they actually got, okay. Okay. And then that gives you some tips on how to give it. Should never double it up, should never repeat the dose if they vomit. What would you be concerned about if you gave a kiddo dig and they vomited?
Dig toxicity.
Yes, good. Okay, if they vomit twice in a row, then you should be calling the cardiology department that's on call. Okay. Keep dig out of a place where kids can get to it, and then contact poison control if they get a hold of it, and then they'll also be given Digibind. Okay, and don't run out of their medications. Okay, PDA. That is what you need while you're in utero for blood flow, okay? That opening between the aorta and the left pulmonary artery, okay? Machine-like murmur. If you give Indocin or indomethacin, it should close without surgery. However, if it does not close with indomethacin, then surgery is required, okay? Usually closes a few days after birth. So tetralogy of Fallot, you're going to have that BSD, okay? You're going to have hypertrophy. You're going to have that narrow opening of the pulmonary artery, okay? And a narrow opening to the aorta. Those are the 4 defects, okay? If it's severe tetralogy of Fallot, then prostaglandin is started. That allows more blood to flow to the lungs to become oxygenated, okay? And for tetralogy of Fallot, if you remember RAPS, that's right ventricular hypertrophy, aortic displacement, pulmonary stenosis, so narrowing of that pulmonary valve, and then septal defect. So ventricular septal defect, and this is a cyanotic heart lesion. And I will tell you that HESI likes to ask about tetralogy of Fallot because there's a lot of defects, okay? We'll keep going until 5 o'clock, okay? Congenital heart defects, so your acyanotic lesions, which is what sort of shunting?
Left to right.
Yep, good. VSD, your ASD, your PDA, and your coarctation of the aorta. There's cyanotic lesions, which is right to left. Shunting is tetralogy, transposition of the great arteries, trunctus arteriosus, and PBR. Okay, and then also hypoplastic left heart syndrome. Congenital heart defects. So you'll start to notice this when kids are pretty little. They'll start having growth restrictions. They're going to have increased pulse, increased respirations. They're going to be having more frequent upper respiratory illnesses, fatigue. They're going to become dyspneic with very little activity. Okay. Poor feeding in infants. Okay. All right, what are you going to do for seizure precautions?
Padded bell reading,
Mm-hmm.
making sure they're safe. Safety and airway.
Mm-hmm. Yep. Yep. So you should have suction set up at the bedside for these kids that have seizure disorders, padding on the side rails. Yep. Good. They should have IV access. Okay. Number status epilepticus. This is where they're having seizure activity for longer than 30 minutes or continuous seizure activity, and they do not have a postictal phase. So they're just kind of having cluster seizures. So one right after the other. Okay. So emergent treatment and intervention is needed, something like diazepam to prevent loss of brain function. Okay. Diarrhea, what acid-base imbalance?
Metabolic.
Metabolic what?
Acidosis.
Yes. Uh-huh. Good. So your signs of metabolic acidosis are headache, drowsiness, confusion, weakness, increased heart rate and respiratory rate. Okay. And you're going to get decreased cardiac output. So that's where you're going to see cardiac arrhythmias. And your treatment of metabolic acidosis is electrolytes. So Pedialyte. Okay. 6-year-old comes into the ER because they've had abdominal pain, fever, and vomiting for the last day. What's your priority assessment?
We need more information about the pain.
Yep. So figure out what sort of abdominal pain they're having. What would be a really concerning finding?
McBurney's point.
Yes. Positive McBurney's point, which is in what quadrant?
Right upper, or is it right lower?
Right lower is McBurney's point. Yep. Good. Which would be a finding that's concerning for what?
Appendicitis.
Yep. Good. All right. Neuromuscular disorders. So cerebral palsy. So these kids will have scissoring while they're trying to stand up. They cannot stand up without crossing their legs in a standing position. Okay. Okay. Good. Yep. So they stiffen up like scissors when they're trying to stand, and then they're also in that position crisscross in front of each other. Okay. And that's with spastic CP. Okay, if there's an amputation that occurs with the PEDS patient, what's your most important teaching for parents?
Monitor for signs of infection.
Uh-huh, what else?
Skin integrity.
Yes, watching for skin breakdown as well. Yep, good. Yep, good. Okay, Synagist, RSV vaccine. It's not really vaccine, it's antibodies. Okay, it's a MAB. So monoclonal antibodies is what the MAB drugs stand for. Okay. So it's given spring through or fall through spring. So about October through March. for kids who are at high risk. So premature kids, less than 35 weeks, they will qualify for Synagis. Kids with cardiac defects, kids with lung defects, chronic defects like that, or autoimmune disorders. When should babies be offered solid foods?
6
What age?
months.
6 months. Yep. Till then, it's formula or breast milk. Okay. The other thing is making sure that they can sit up and they can hold their head steady and know to open their mouth when the spoon is coming towards their mouth. Okay. And then one new food at a time to make sure that they're not allergic. However, this recommendation has changed, but our books have not caught up yet. Okay. The only foods you have to do one at a time are the highly allergic foods like peanuts, tree nuts, soy, sesame, dairy, eggs, fish. Okay. But our books haven't caught up to that. So one food at a time to monitor for allergies. Okay, when and why would a lab test be, or a Lyme test be done on a child?
If they've been in woody areas, that's for sure.
Mm-hmm.
Tick bite.
Yep, if they've had a tick bite. What about if they didn't have a tick bite, but they notice what sort of rash?
Bullseye rash.
A bullseye rash. They would need Lyme test. Yep, good. So this is literally what the bullseye rash will look like. So you're looking for the Lyme, Borrelia burgdorferi. Okay. This is a contaminant that happens when you're bit by a tick. And your Lyme test will not be positive until about a week or 2 weeks after exposure. Okay. And that's usually when this rash appears, is around that time. Fever, rash, flu-like symptoms. Later on, if it's not treated early with antibiotics, then you'll get the neuro involvement, so headaches, joint pain, things like that is what you'll see later on. Doxycycline is usually given. Okay. Here's your early localized, so all of your symptoms that you'll notice with Lyme. The biggest thing in teaching for Lyme is to make sure that these kids are not getting bit by ticks, so using tick repellents. Showering after being outdoors, checking themselves for ticks, and then see a doctor right away if you go outside often and you notice fever and rash. Okay. Are you guys over it? Okay. I don't blame you. I understand. Okay. If you guys want to sign up for our meeting times, that announcement is on the course cafe. Like I said, that's for week 12. Next week, your attendance will be taking your HESI. So as soon as I see that you take your HESI, you will get your attendance for next week, okay? And if you miss like 2 weeks in a row of attendance, then they can drop you from your next course. So make sure you check in with me. It's super easy, week 12, okay? And if you're totally freaking out about your exam, you can send me an email and I can tell you if you pass, okay? But just know that that might change, you know, as we review all the exams for fairness, okay?
Yes, I'm gonna email you.
Okay.
You said email you for this exam, or are you talking about for the HESI?
No, for this exam.
Okay, I'm emailing you right now.
Okay.
Oh, can we just all get a mass message?
Do you want me to
Will you
email
just
you
send us
all?
a preliminary grade please?
What?
Can you
Appreciate
send
it.
us a
Email us
preliminary
all. Just
grade
tell
or
us if
something
we're
for
in
the
the safe
something
zone.
for now?
I can't say your actual grade, but I can say whether or not you passed. Okay.
Please do
Okay.
that for me, please.
So for those of you, just shoot me an email really quick. Just say exam question
I
mark.
got a
Can you
notification
tell us
just
the
now that
class
said it.
average right now? Like, is that something you're able to do?
Yeah, let me see if it'll work to pull up.
I
just got a
literally got the
message.
same notification. She said I got the notification that it was graded and I could see it.
Yes, and I went to go
There
look and wasn't nothing else.
was nothing there. I don't
Okay,
know.
let's see. I'll tell you guys here in just a second. It's taking a while.